Okay, now we're in place. And we start. It opens. The filmar. Closing again. And we do it once more. And then you see the lesion is completely gone here. Hi, I'm Trygve Eriksson. I've been a radiologist in Östersund for 22 years, in the middle of Sweden. I would like to welcome you to this film, and we will talk about vacuum-assisted excision. And it's all about this special needle. It makes it possible to remove a benign lump in the breast without open surgery, without sedation, just leaving a small scar and letting the patient leave the hospital some hours later, and exactly the same good result as open surgery. I've made a model for you, made of vegetables. The peas are the breast, and the tomatoes, that's the lesions. And now we're going to use our needle to take away the lesion. And this is a needle. It's like a big pipe, but it's very sharp. It's got an opening here, and then it's got a knife, and it cuts. Look. It opens. It sucks. And then it's closing and cutting. I think you understand the principle. Now let's try it on our model. Let's remove this lesion. I'm introducing the needle, you can see it. Working my way through the breast tissue. Here I'm going right under it. There. You can see. Stopping there, there we have our opening. And then I'm start opening it. It sucks. And then it closes again, cutting away the lesion. And I keep doing this. Now the next one. And it cuts again. Opens again, sucking. Closing. You see the lesion disappearing more and more. Here you really see the suction, the air coming in our model here. And now we're done. We've taken away the lesion, and I take out the needle, and actually the lesion is inside here now. Now it's time to leave the vegetables and go to a real patient. Hey!
Hey!
Our room is not so big, but we are just 4 people, so it works fine. So as you can see, we have prepared with 2 10mm syringes with local anesthetics, and we use adrenaline. And also we have prepared with 3 syringes 10ml with saline that we can use later, as I will show you. Lisa, the nurse, is expanding the opening to fit the breast. Okay, now it's almost time to meet our patient, but first I would like to introduce our excellent team. We have my colleague here, David, and then we have PG, The nurse, he will mainly occupy himself with the patient. And then we have Lisa, who will assist me. We have a sterile setup because it's easier to work like that. But you can do it with less than this. Here we prepare the needle, pushing it through the plastic cover. So all our equipment is sterile, so I can use it without problem. Är vi klar?
Ja.
Okay, since we're almost ready now, I'm going to talk to the patient now. Okay, so now Lisa is dressing the patient. Also using an arch here, so the patient don't have to see the needle. Hi there, are you okay?
How are you doing?
Great. So now I'm doing a very important thing to locate the lesion and planning. So now I've just put something subcutaneous, and I will go on with a marker. I use a marker because I don't want to lose track of the lesion while I'm putting in more anesthetics. Okay, here's the marker needle, and I continue to the lesion. So there we have the lesion and the tip. Okay, now we can see the marker there and the lesion together. Bra. Går det bra för dig?
Ja.
Yep. Okay, and now we take some more anesthetics. Now go under the lesion, putting some more anesthetics there. You see the black. Okay, everything is fine.
Yes.
Doesn't hurt anything.
No.
No, good. I'm using the saline to loosen the lesion a bit from the surroundings. Okay, so I'm done with the anesthetics, and I just wait a couple of minutes. I use a scalpel to cut the skin. Doesn't hurt?
No.
Good. It should be like that. Before I use the needle, the scarring gets much less prominent that way. Remove the safety. So now we have the lesion with the marker beside it. Now I'm entering the vacuum needle through the pre-cut skin. Remember to keep track of your needle tip.
Nej, precis.
Always keep the needle tip and the target in vision, so you don't proceed blindly. Okay, now we're in place. And we start. It opens. Du filmar. Closing again. I will do it once more, and then you see the lesion is completely gone here. And also the marker disappeared. I do it once more here. Hang on here. Just to be safe, we have done it with margins. And a closing again. Okay, fine. Now we don't see any lesion left. I can just do some vacuum here without cutting anything.
Yep.
Are you okay?
Yes.
Good. No obvious bleeding here. So I take out the needle. I check again if there's a bleeding here. But there's no big bleeding here at all. Now I'm going to put in a marker here. A marker. I'm putting it in the vicinity where I was before. Actually not directly in the hematoma, but in the soft tissue beside it. There. So we can find our way back if we need to. Varsågod. And now I keep compressing. Okay, now we're almost finished. I'm just going to compress a little bit more, and then it's time for the strips. Okay, so here we have the result. We have 3 biopsies. So inside here we have the papilloma, and I will put them in the formalin here. This is 3 samples, and then we'll go to the pathologist and we'll see the result. And now a good advice. This plastic sterile cover, it can make a vacuum inside. So it has happened to me a few times, and then the button here is locked. So to avoid this, I do a small cut here on the sterile side of the plastic like this. And that allows the air to come in and prevent the problem with the vacuum. After I've done that, I haven't had any more problem with the vacuum inside. Welcome back. Now you've seen the procedure and the tomato, and we will dive deeper into the subject. These are the things we will talk about, and we start with the benefit, of course. No hospital admission. The patient can go back home directly afterwards. Local anesthesia. No general anesthesia and no risk with that. And on top of that, small scar, just 3 to 4 millimeters. Look. Here we have a breast with 2 scars. This red long one is from open surgery, 4 centimeters long. And this one, just 3 to 4 millimeters from VAE. And you can easily understand the difference for the woman. This is a breast after 7 months. And this is my thumb. And that's the scar. It's nearly invisible now. There are less complications than open surgery, and the recovery, it's much faster. Now we'll talk about basic interventional ultrasound. This is a breast, and here you have an ultrasound probe, and this is what you see here. It's a slice just that gives a picture. And this is a lesion here. I think about it as a book here. This slice here, that's a yellow line, as a chapter. The frequency of the probe, if you have a high frequency, then it's a tiny chapter. And if you have a low frequency, then you have a big chapter. But you want the resolution, so I always use a 17 megahertz probe. That gives me the best resolution, and I can see the really small details. But you have to remember to stay within the chapter. So the chapter is smaller, and you have to have your needle within the chapter, otherwise you'll lose the tip. However, frequency and penetrance are connected. A low frequency probe has deeper penetration, and sometimes I have to use a deep penetration to catch a lesion that is deep down in the breast or in difficult areas. But most of the times you're better off with a high frequency probe. Now we'll talk about puncture angle and the reflection of the needle. You can see the breast here and the muscle here, and here you see the probe, and this is the picture you see, and the lesion. And here's the needle coming in. But you have a problem if the needle angle is too steep. The energy here from the probe, it bounces on the needle tip or the needle and go back here. But if it's too steep angle, then most of the energy bounces away, and you got just this small green energy coming back that gives you the picture. But if you have a flat angle here, much more of your energy will bounce back to you and give a picture, and just a small fraction is spoiled. Now we'll talk about movement axis. You have your breast here, and the breast, of course, they come in different sizes and shapes, so they move. You have your probe here, and it's also moving, and you can also turn it. On top of that, you have your needle, you move it up here, and it moves inside the breast. And here we have a breaking point, so when you move it on one direction, it moves on the other direction here. Look, here you have a needle, and you turn it there, and it moves like that, almost always. And then we have our lesion, and the lesion is also movable. So with all this complex system, you need to remember one thing. Always focus on the lesion and the needle tape on the same time. You must see them both, otherwise you will miss it. You will miss to take the good samples. Now let's talk about the indications, the contraindications, and anticoagulants. The techniques and indications may vary depending on different countries and local regulations, of course. It is primarily used to remove benign lesions like fibroadenoma or papilloma. You can also use it to remove bigger biopsies instead of open surgery. It can also be used for B3 lesions. VAE is used for B3 lesions, uncertain malignant potential lesions, since 2016 in UK. Detailed guidance in the NHS BSP assessment guidance document. Other countries that uses it for B3 lesions are UK, Spain, Portugal, Russia, Netherlands, Poland, United States, and Canada. The B3 lesions, they are atypical intraductal epithelial proliferation, classical non-pleomorphic lobular neoplasia, flat epithelial atypia, radial scar with epithelial atypia, papillary lesion with epithelial atypia, mucocele-like lesions, and finally radial scar or papillary lesions without epithelial atypia. We have also second-line indications. We can use it in a palliative manner on non-operable patients with malignancy to reduce the tumor burden. And remember, it is a tool, so we can use it, for example, to remove bigger hematomas. One important thing. Before a case is considered for VAB or VAE, it should be discussed in the multidisciplinary breast group. And now we'll go on with the contraindications. There are no absolute ones. It's still a dialogue with you and the surgeon. The size of the lesion can be a problem. Don't do it over 4 or 5 centimeters. And it's also depending on the size of the breast, of course. It's easy to leave things behind and then you have to do it once more. Finally, we have the anticoagulants. And this is a Swedish recommendations. We have ASA, and that's okay. We have warfarin, okay, if it's within the interval. Clopidogrel here, you have to remove for 5 days. And we have NOAC, so in breast it's low risk. And then you have to remove it for 1 day. If the patient had kidney failure, then it's removed for 2 days. When we reintroduce the drugs, normally we do it the next day. Lesion size and time are of course connected. Estimate around 10 minutes per centimeter lesion. And that means you can do a 2 centimeter lesion within 1 hour. I would recommend that you start with a lesion less than 2 centimeters and then you won't have any problem. In our film you saw 4 persons. You can do this on 1 or 2 persons. I prefer 2. Then you have one who is sterile and one who is non-sterile. I would recommend that you start with a small team so you can be good at this, and then later you can learn more assistance, and then you will have a good result and at your hospital. So this is our room. It's middle-sized. And what do we need to perform VAE? You need a vacuum needle, we use 7G, and a vacuum machine. We use markers, and we need a dressing set. We used a pre-packed nephrostomy dressing set because it contains what we need. We need an ultrasound machine, and also would like to recommend an extra monitor. It's good for the ergonomics. When I'm standing on this side, I can see the monitor straight over. Now it's time to show you the things we need for the operation. And as you can see, I put it on display for you. I have 2 syringes with anesthesia and 3 syringes with saline, 10 milliliters. I use a green long needle, 8 centimeters. I like long needles. And I also got a blue small needle if I like to put a roof truss. There are no fancy stuffs. We have piangs, we have a scalpel, gloves, saline. This is a jar to put the samples in, and we have compressors here. We have strips, we have gel, we have protection for the ultrasound probe, we have protection for the machine, we have coverage of the patient, and we have surgical gown here also. Hello Marie-Louise, welcome.
Hi. Thank you.
Today we're going to do that small surgery we talked about.
Yes.
So this is how I normally meet my patient. And Marie-Louise, she's of course a figurant. The paper we got here, she's got that already at home, and it explains how the procedure is done. We have a brief explanation about the procedure. talking about the scar for like 4 millimeters. I have some anticoagulant information, the use of paracetamol and avoiding NSAID. They can use headphones to listen to music if they like. They should avoid heavy exercise for 3 to 4 days afterwards and using a supportive bra. Avoid water for 5 days and leave the tape on for 5 days. Afterwards, when they shower, they can put on some new tape, and that can go on for up to 3 months. But normally you don't have to do this because the scar is so small. The bruising can persist up to 6 to 8 weeks. And you should avoid sun for up to 1 year or using sun protection like sunscreen protection factor 50. So now I have the patient in place. I raise her up so it's easy for me to work. Come a bit closer to me. That's fine. And then roll over a little bit like that. Thank you. I'm using a pillow like this. And fall back on that. Thank you. The aim for me is having a good working conditions. The patient should lie stable and at the right level so I can lean my hands on her. The patient should of course lying nicely also. So I'm using a pillow between her legs. Like this. Is it okay?
Yes.
And fixing with her head also. So we'll lift it up. Feeling comfortable?
Yes.
To support the patient even more, I can use the cloth to support her arm. Thank you, fall back. And then catch the arm like this. So now she can rest her arms in a secure way. The needle can be a bit scaring for the patient, so that's why we build this thing. It's an arch that we can hang a cloth over to protect the patient from the sight. To sum it up, the patient is lying comfortable, she's lying close to me, I have good working conditions, and I can lean my hands to be stable. The VAE procedure. It's a little bit like I'm planning a mountain trip. This is a map over my home mountains just outside my window. And this is when I'm looking at old pictures. I'm looking at the lesion and recognize it. After that, I'm meeting the patient and find the real lesion. And that is a little bit like looking at the landscape. I find the lesion and I'm trying to find the best way into it, trying to avoid the fibroadenosis if it's possible, and taking an easy road in the fat. After that, it's time for the performance. I'm walking up in the mountains and I'm doing my VAE. And now we'll talk about another important thing. Areas to avoid with the incision. The upper part of the breast are more likely to give big collagenous scars. So this is the area you should avoid with the incision. You can always access these areas from another direction like this. The orientation of the incision, use these concentric circles and use your scalpel like that, and that gives you the least prominent scars. Now it's time to talk about local anesthesia. This is a needle here, and here you have your probe and the lesion, of course. I start by putting the needle straight down, giving local anesthesia subcutaneously. The distance here between the probe and the needle is 5 to 10 millimeters. Then I turn the needle continuing down to the lesion and giving local anesthesia around it. I use mepivacaine 10 milligrams per milliliter up to 20 milliliters, and it contains adrenaline 5 micrograms per milliliter. I use adrenaline, and if you're worried about that, this is an article from the Swedish doctor newspaper Läkartidningen, and it says, "Time to bury the adrenaline myth. It's safe to use adrenaline even on fingertips and nose tips." To easily perform the excision, you can free the lesion with saline. Here's a lesion, you see the saline coming in, and it separates the tissue around it so it's more loose. Then you have your VAE needle. I try it to get more horizontal, and it goes in. You see the opening, it's straight under the lesion. It opens, the suction is on, and it cuts. In real life it looks like this. Here you can see the needle coming in. Here you can see the lesion. And this is an opening here. Now you see it's coming down, and you can even see the marker there. And then it cuts again. Now we'll talk about markers. I tell my patient that I look upon the breast as the moon. I've been there and I've found a small spot, and I have to find it again because I need to know where was it. Then I use a marker and plant it like a flag, and I can easily go back the next time and find it. These are the marker indications. Markers give objective confirmation of correct lesion or location, a small hard to find lesion, or a lesion removed entirely. To establish the location of borders of a malignant tumor before neoadjuvant therapy, because the lesion can disappear completely. And then to correlate ultrasound with the mammogram. This is how I do it. Here you have the marker and the small lesion. I go in close to the lesion or in the lesion and putting the marker there. In reality it looks like this. This is a papilloma here, and here you see the marker needle. And if you look closely you can see the marker coming out there. It's coming there. There you see it. And afterwards it looks like this. This is post-op. You see the round marker there. Now it's time to show you the procedure on a phantom. You will see it down there on the monitor, and I have my own monitor. This is our pillow patient, and I made a phantom of my own. Here you see it. I put it here. It filled with vegetables actually. Now it's time to locate the lesion. I'm using my right hand when I'm doing the diagnosis and serious stuff. Here we have the lesion. You can freeze there. Here we have the lesion. Up here, that's the skin, and this is further down. It's time to do the anesthetics. And then I change my hand because I work with my right hand now. And as you remember, I go straight down first, and then I turn it, putting some anesthetics under the skin here, if you'd like to see it. So I go under it, putting an anesthetics. Here you see the tip or other side there. I go up here. over the lesion. In my phantom, the anesthesia disappears, so it's not perfect, but it works. I'm putting anesthesia on the sides also, so I follow the lesion on one side and moving my needle. I will catch it. Okay, you see needle tip, and there I put some anesthetics there on this side also. Go back again, keep track of your needle tip. There you have your needle tip. And it disappears, there it is. And you take it on the other side too. Okay. Fine, we're done. So now I've put the anesthesia around the lesion. And it's time, we wait of course a while, and then we're doing our VAE. If this would have been a very small lesion, then it can disappear when I'm putting the anesthesia in. So that is, I have to put a marker before I put all this anesthesia in. I'll show you how it works. To show you the marker here, I've changed phantom. This phantom has small lesions, and I will show you. You see the lesion here, and I'll go in with a marker. I do exactly as I did before with anesthesia. I go first straight in. I'm finding the needle tip here. Let's see where it is. There you see it. And you can either put it inside, or if it's very small, you put it right in front of it. And here I will put it in front of it so you can see it. Not soon coming out. There you have it. Up there. Coming out round there. Okay. Now it's in place. Can you see it? Freeze. There. You have it there in front of it. Now we're back at our model. Freeze. We have a look at it. Unfreeze here. You see it. It has a very calm surrounding here. So in this case, I wouldn't need a marker. But if it's very dense or fibrinotic area around, then I would have put a marker beside it here. I will show you how to put the incision now. You remember the circumferential lines that we should use, and when you do the incision, you just push the scalpel straight in like this. That's enough. And you got your incision there. Before, when I did the anesthesia, I went rather close here, go inside the breast. But now when it's time to do VAE, you want to do a more horizontal entrance, as I told you before. So then I go further down on the breast and entering here. Okay, here is the needle, you see it coming in there. And you see my lesion here, and I go straight under it. There you see. Now we're really just under it. And it's time to do our VAE. And there's the suction here. And it cuts. And I continue. It disappears more and more. You can adjust the needle a little bit. So I have a look here. I do some suction here just to remove the air that's coming in here. Let's see if we have anything left here. I say we are done here. We have taken out the lesion. Okay. The lesion is gone and it's time to put in the marker to establish the place. I entered the same close hole as before. There's the marker tip, and here it was. I put it in a close vicinity, not directly in the hematoma. Let's see if I can catch this on film. There you see it popping up. Can you see the round? Done, and it's easy to find our way back if we have to. When we are finished with the VAE, what do we have to do afterwards? It's time to compress the area. Put my hand like this and compress it. I compress it to 5 up to 10 minutes depending on how much bleeding there was, and normally there is not a lot of blood, so 5 minutes, that's sufficient often. Now it's time to put the strips on. Fasten it like this. I put it star-shaped. Okay, the strips are in place and we'll leave them on for 5 days. I put on a small bandage. I tell the patient to use paracetamol as was told before. Avoid heavy exercise. Use a supportive bra. Avoid water for 5 days. Leave tape for 5 days. And after having a shower, use a tape for up to 3 months. Then we have a follow-up after 3 months. I want to see the result and also see if there is something left. In that case, we can do another VAE. Now we'll talk about some difficulties you might run into. Big moving breast, as we said before, they come in all sizes and shapes, and it can be like a bunch of footballs there that you have to keep together, like a net here. You can fix the breast with tape actually, so it won't move around so much. You might also run into very tight conditions close to the skin. So then you have the saline here, and here our lesion, and it's close to the skin. Then you can go in with saline and push the lesion down so you get more space to put your VAE needle under. You have to protect the skin. If it's really, really tight, you can also put a roof truss above it between the lesion and the skin. And I use a needle like this, so it lifts the skin from the lesion so I can work under here. This is how it looks for real. You see the needle coming there and the lesion is here. It's hard to see. Now you see the needle going up and the lesion here. So the needle protects the skin and holds it up. Now we have a problem. This lesion is close to the skin. Look, here you have the skin, here you have a lesion, and here it's very tight. So we need to expand the area with saline. We'll do that. I have my saline syringe here, and I'm going in straight down first. We see the needle dip is coming in here. You see it, I'm putting on top of the lesion, and then I'm pushing in saline here. You saw that the lesion went down first and then it went up again because our model is not perfect, but in real life it works. I will also show you the other way to protect the skin using a needle as a roof truss. I have my needle here, coming in and placing it between the lesion and the skin, so it protects the skin when we're doing our VAE here. There's it. You might run into a late surprise. What if it was a malignant histopathology? Well, no worries. You have your markers, and it makes it easy to return to the place and letting the surgeon do that part. If you got non-radical excision, you do a new VAE. I have some good advice for you also. Relax. Don't push the probe too hard, because that is what we normally do if it's difficult, but often it works out if you lift the probe, keep it nice. Support your ultrasound hand here on the patient, so you fix that, and you have your lesion in center, because that's your center. If you're lost, don't advance. And if you wonder where your needle tip is, you see the needle like this. Let's find it here. There you have your needle tip. And if you rotate it here, you can see how it changes there. Then you confirm this is my tip, because otherwise you can think, oh, there's my needle. But actually your needle tip can be far away, far away. It's there now. So rotate it, then you see it. So that's easy to lose sight of it. If you don't know, you can look down and see if your needle stays like this and your probe like that, then you're lost. You can line it up if you look down. And if you are really lost, you can move this probe towards the needle, catch the needle again, you can drag back your needle, and they meet there in the entrance, and you keep doing what you're supposed to do. I think with these advices you will be doing fine. Training. You must train. It is the key to success. And you can make your own ultrasound phantoms like this. I use tomatoes and I use a glove, and that works perfectly. I even give you this recipe for to do it. Or you can buy them, of course. Shall we summon everything up now? Train on phantoms, as I said. Start with the easy cases. Up to 2 centimeters, and not in top up at the skin, but in the middle of the breast. Train a small crew, so you will work fine together. And stand comfortably, both for you and that the patient will lie comfortable, at ease, and to be able to lie still for a long time. And of course, always the target and the needle tip in focus. Never lose them. It's not that difficult, as you have seen. I would like to thank you for attending this film, and I wish you good luck out there. It's been a real pleasure. Thank you.